The second area of high risk in pregnancy is hypertension. And there's two definitions. Either you have a sustained blood pressure elevation of 140/90 millimeters of mercury, and you need to have that in 2 or more measurements, or you have an elevation of 30 millimeters of mercury systolic or 15 millimeters of mercury diastolic over the first trimester or pre-pregnancy value. This definition is important because if you have a patient whose blood pressure runs 90/70, then it only takes having elevation of 120/85 to be considered hypertension. And we normally wouldn't think of that as high blood pressure. Two types of hypertension. Either your patient has chronic, also called essential hypertension, or they have hypertension related to pregnancy. In other words, they already have hypertension prior to becoming pregnant, or the hypertension starts with this pregnancy. Let's talk first about chronic hypertension. Their blood pressure is elevated 140/90 or greater prior to pregnancy, so not related at all to the pregnancy. It's usually associated with arteriosclerosis or renal disease, and this tends to be a problem of older pregnant women, but it's also related to obesity and diabetes. And they're also at risk for the development of hypertension related to the pregnancy on top of their chronic hypertensive state. This is a high-risk status because the fetal well-being may be compromised by this chronic hypertension by poor placental perfusion. These patients should always be followed by an internist during pregnancy along with their OBGYN. It's important to document adequate fetal growth, get baseline renal function studies, and just the overall medical management of their situation. These infants of these women with chronic hypertension tend to have retarded fetal growth or may even be stillborn. They may have fetal distress in labor due to that poor placental perfusion, and abruptio placenta is more likely to occur because there is increased vascular tension, and that leads to rupture of the placental capillaries. When we look at medications for women who have chronic hypertension during the pregnancy, you have to be choosing medications very carefully. Antihypertensives that can bring their blood pressure down are not always advised because they may reduce placental blood flow. And so you should only initiate antihypertensives if their diastolic blood pressure is consistently greater than 100. Aldamate, which is an old antihypertensive, is really the best drug of choice during pregnancy because of its record of safety and effectiveness in pregnancy. Now, beta blockers and calcium channel blockers may also be used if that aldamate is not effective, but ACE inhibitors are contraindicated in pregnancy. You can use them in the postpartum period, but not during pregnancy. Hydrazoline is a vasodilator, but you reserve it for any hypertensive crisis. And we really try to avoid diuretics if possible, especially if they already have superimposed preeclampsia, because it may further shrink their blood volume. So let's now move to the more common situation of hypertension during pregnancy. Its definition is onset of hypertension after the 20th week of pregnancy, and it appears as a marker of a specific vasospastic condition. So this condition is unique to pregnancy. It is fairly common. It occurs in 5 to 10% of pregnancies in the United States, and despite many years of research, the cause is still unknown. We do know that it's a systemic disorder. It affects almost all organs, and the basic cause of it is peripheral vascular spasm. But the big question is, why does this spasm occur? And that's been very difficult to establish. We have predisposing factors of the hypertension in pregnancy, the younger primates or the older primates, low socioeconomic background, multiple pregnancies greater than 5, women of color have more hypertension in pregnancy, and women with hydramnios, remember that a large amount of amniotic fluid, any woman who already has underlying cardiac disease or diabetes, or the history of essential hypertension, those would be predisposing factors for hypertension in pregnancy. Now we're going to look at the 5 different categories of hypertensive disorders, starting with gestational hypertension. This is where women have increased blood pressure related to their pregnancy, but they don't have the proteinuria or the edema. And this ends up being a benign condition, although you need to monitor them carefully and watch them for progressive problems with the proteinuria or edema. But if it stays as a benign condition, the perinatal mortality is not increased at all. Then we talk about preeclampsia. Preeclampsia also could be called pregnancy-induced hypertension. But preeclampsia is a good term because eclampsia means seizures, and preeclampsia is the condition prior to the woman developing any seizures. It is dangerous to the expectant mother and the fetus because it can develop and progress very rapidly, and the early symptoms are really going unnoticed by most women, and they often progress to the advanced state. So you've got valuable treatment time that is lost. So if we look at the pathophysiology, we have vascular effects first. The cardiac system is strained as that heart is forced to pump against the increased peripheral resistance because of all the vasoconstriction from the vasospasms in the periphery. This reduces blood flow and blood supply to organs, and the ones we're especially concerned about are those vital organs, the kidneys, the pancreas, the liver, the brain, I would also say the heart, and then the placenta. So this causes increased blood pressure from those vasospasms. And then the spasms of the arteries in the retina can lead to vision changes. And if it hemorrhages, you actually can have blindness. And then you have ischemia of the pancreas because of it not getting enough perfusion, and that causes epigastric pain. We also have kidney effects. You've got vasospasm in the kidney, and the degenerative changes in the kidney, glomeruli, are occurring because of that back pressure of the vasospasm. So this leads to increased permeability of the glomerular membrane, allowing serum proteins to escape into the urine. And we call that proteinuria. Now remember, proteins are huge molecules, and so they normally you're not going to find them in the urine. You have to have holes in the glomerulus, and that's what we mean by permeability, means that you have holes, and that's the only way that you can have protein escaping into the urine. Those degenerative changes also result in decreased glomerular filtration, so now their urine output goes down. And this is very life-threatening to the fetus and the mom, especially if it is unrecognized. Lastly is the interstitial effects. The arterial spasm causes the blood volume to pool in the venous circulation, and then you have diffusion of fluid from the bloodstream to the interstitial tissues, causing edema. So what we have is this classic triad of symptoms with preeclampsia. You have the hypertension, proteinuria, and edema. You must have all three of these. We already defined hypertension, and remember, if the blood pressure is difficult to bring under control, then you can have cardiac and pulmonary complications in addition. The proteinuria, we have a definition here that either you have an excretion of 0.1 grams per liter in any random specimen, or it's much more accurate to get 24-hour urine where you have 0.3 grams per liter, or we actually just do a urine protein dipstick, and all it takes is 1 to 2 plus protein to be considered proteinuria. And when you have this presence of protein and it gets more extreme, goes from 1 to 2 plus to 2 to 3, 3 to 4, this indicates a worsening of the disease process, and now you have an increased risk to both mom and baby. There's a positive correlation between the degree of proteinuria and the perinatal mortality and fetal growth restriction. Lastly, the edema, and this is where you have intracellular as well as extracellular edema. So you have generalized and excessive fluid in the tissues. As the vasospasm gets worse, you have increased risk now of pulmonary edema. So this edema is not just the swelling of hands and feet and ankles that a lot of pregnant women get after being on their feet all day. This is generalized body edema, and the sign that we watch for that indicates the situation is more ominous is the facial edema. Once they have that facial edema, it has pretty much spread everywhere. So let's talk about the degrees here. Mild preeclampsia. This is at the minimum. Their blood pressure is 140/90, or it has just increased that 30 or 50 millimeters of mercury, depending on systolic or diastolic. Their proteinuria is 1 to 2 plus, and because of the edema, and it's mild, but because of that, they've had a weight gain of 1 to 2 pounds per week. Severe preeclampsia, their blood pressure is higher, 160/110. Protein is 3 to 4 plus. They're oliguric, and they'll have cerebral or visual disturbances, extensive edema, and when it gets to this point, the fetal mortality is about 10%. So the goal is to prevent seizures and maintain the pregnancy until it is safe to deliver the fetus. Basically, each day, the physician is evaluating whether it's safer for that baby to remain inside mom versus outside, depending on the severity of her preeclampsia, and so that his baby is watched carefully every day. Eclampsia, as I mentioned earlier, this is characterized by the onset of seizure activity, and this is because you have so much now cerebral edema. Once you have eclampsia, the mortality rate for mom is up to 15%, and the fetus is up to 25%. So we teach moms the symptoms to report if they have a continuous headache or drowsiness or mental confusion. This could be due to poor cerebral perfusion, and it may be a precursor of seizures. We teach them to report any visual disturbances, blurred or double vision, or any spots before their eyes, and this is indicative of arterial spasms and actual edema of the retina. The epigastric pain, this is an especially ominous sign, and this indicates that there is distension of the hepatic capsule, and this also often warns them of imminent seizures. What happens here is that the liver is involved. When you have epigastric pain, we now know that the liver is involved because the liver lives inside a capsule. And as that liver becomes sick, it becomes enlarged, and it's pushing and stretching and distending that capsule around the liver. causing epigastric pain. And then they will have decreased urinary output because of the poor kidney perfusion. And they can actually develop acute renal failure. And then, of course, they're always at risk for chronic renal failure, that it may not turn itself around. The most severe form of preeclampsia is called Hellp syndrome. And at this point, we have the liver involvement. The H stands for hemolysis, and that's the breakdown of red blood cells. The EL stands for elevated liver enzymes, and the LP is low platelets. So you have all of these things because of the liver involvement. Now, once it gets to be Hellp syndrome, it becomes a multiple system disease and multiple organ involvement and damage. Again, as I said, it's the most severe form of PIH or preeclampsia, and it occurs in 4 to 12% of patients who have preeclampsia. Preeclampsia tends to be a disease mostly of primaps, not always, but mostly. But Hellp syndrome occurs in primaps or multips. It doesn't care. And it accompanies either late pregnancy, so it goes along with the preeclampsia, either in late pregnancy or just immediately after birth. And the therapy here, along with other treatments, is to improve the platelet count, and we'll use fresh frozen plasma or platelets, whatever we need to do, and deliver the infant as soon as feasible, either vaginal or C-section, whatever is going to get that baby delivered fastest. So if she's already in labor and progressing, they'll continue with that vaginal delivery as long as the fetus is stable. So we're going to look at this case study with a patient who's a gravida 1 at 34 weeks, and she's there to visit the doctor for a routine prenatal visit. And when the nurse weighs her, she finds that she's gained 8 pounds in the past month. So we look at what is the main objective after this initial assessment, and what is the most important question or problem that must be solved during this visit, and what are the nurse's priority assessments and why. So we'll be talking about this case study in class. The nurse is going to get a clean catch urine specimen and take her vitals. She'll check fetal heart tones and deep tendon reflexes and check for clonus. Remember, clonus, we'll talk about that, what that is. But it's always checking for hyperreflexia. So 3 more questions. What testing would you expect to be done on the urine specimen and why? And what information might the nurse need from those previous prenatal visits and why? And what questions should the nurse ask this patient while assessing her? So after all of this, the physician diagnoses her with mild preeclampsia, and because it's mild, will initially manage the patient at home. So what findings would lead the physician to this diagnosis, and why do you think the physician is recommending home management at this time? And then in regard to home care, what teaching is important to be done? So we look at nursing care and management, and the first thing we come up with is a nursing diagnosis. And so probably priority here is altered tissue perfusion related to that vasoconstriction of the blood vessels. But we also have fluid volume deficit, high risk for fetal injury, and then social isolation if she is on bed rest or restricted activity. So our interventions after we have our diagnosis is first of all to promote activity restriction or bed rest. So we would like her to be lying down and resting as much as possible, because this is going to increase secretion of sodium. Remember that the recumbent position always encourages diuresis. That's because of that shift in fluid from the lower half of the body to the thorax, where now you're having that stretch of the chambers of the heart, specifically the atria, where the ANP, atrial natriuretic peptide, is released, and that acts opposite of aldosterone. And aldosterone, remember, causes you to retain sodium and water. So if this works the opposite, it causes you to diurese, to lose sodium and water. While she's recumbent, we want her to be in the left lateral side because this position always increases circulation to the placenta and the fetus. And she's either going to be doing this at home or the hospital, depending on how compliant she is and how severe the situation is. We want to promote good nutrition. She needs a high protein diet. And even though she's got renal involvement, this would go against the normal, usual diet with kidney problems because she's losing so much protein in her urine. She needs high protein diet to replace it. And then she needs good emotional support. So we're going to be attempting to provide that and helping the family to do so. Also, she needs blood pressure assessments, weigh daily, urine dipstick for protein, and watch for signs of worsening condition, and then watching and evaluating the fetus carefully. What you will often see is diminished movement as things are getting more severe. Now, interventions for severe preeclampsia, there's no ifs, ands, or buts about it. She needs to be hospitalized. We are going to monitor the maternal well-being by checking her blood pressure every 4 hours. She needs daily lab work where we are watching the CBC, the platelets, liver function studies, the BUN, and creatinine. Monitor her urine output. She's probably going to be on a 24-hour urine protein assessment, daily weights, and she needs a very quiet environment. Padded side rails, 4 side rails up. We want to decrease stimulation because that is going to decrease the risk of seizures. Monitor the fetal well-being. I already talked about the safe environment with the padded side rails. Promote relaxation. She's going to have almost constant nursing observation, again avoiding stress, limiting visits, and allowing her to verbalize her feelings and her fears. And then we're going to be thinking about induction of labor. So if the maternal or fetal condition deteriorates, we're going to induce labor. Vaginal birth is always our first choice because of the depression of the coagulation factors and other multi-system involvement is going to add to that surgical risk. However, sometimes we don't have that option, and she will be delivered by C-section. Medications would be our next part of interventions. She needs IV access for emergency meds and IV fluids to increase her blood volume and the concentration. Hypotensive drugs may be used here. Low-dose aspirin is going to decrease prostaglandins. And then mag sulfate is going to be our drug of choice because it's going to reduce edema by causing a shift in fluid. But it also, main reason we want to use it is that it's a CNS depressant. Remember, magnesium acts like a sedative. So we would like to give her that sedative effect to decrease the risk of seizures. It also, as a byproduct, will bring her blood pressure down, but that's not our main reason for giving it in the situation with preeclampsia. The caution here is that magnesium is excreted in the kidneys, so we need to monitor her urine output. We need to be sure she has appropriate, adequate kidney function. Otherwise, we're looking at a situation with magnesium toxicity. And we already said that these are women who don't always have the best renal function. So symptoms we look for would be that decreased urine output, depression of respirations, decreased mentation, and decreased deep tendon reflexes. That is because of the sedative effect. Now, one weird thing with magnesium, all these women are going to have flushing and warmth. That is a normal situation with with magnesium and doesn't necessarily mean toxicity. We need to notify the physician and administer calcium gluconate. That's given slow IV. It is the antidote to make toxicity. And the weird thing about that is, I said magnesium acts like a sedative, so does calcium. Both of these electrolytes have a sedative effect. So it's weird that you would give them a sedative when they already have too much sedative. But in the presence of each other, they deactivate each other, and calcium gluconate is our drug of choice as an antidote to make toxicity. Now, what if the patient goes into eclampsia? They start seizing. What are we going to do? Well, eclampsia can occur either antepartum during the pregnancy or intrapartum during the labor and the delivery, or postpartum. And with eclampsia, most of it occurs either during labor or postpartum. In fact, I worry about these women much more so the first 24 hours after delivery than any other time. The immediate care is like with any patient having seizures. Maintain a paved airway. Turn them on their side. Stay close by so they don't injure themselves. Make sure they're getting adequate oxygen. You might give them O2, check their pulse ox, and don't use tongue blades. Remember, that is no longer a treatment option. You need to do a very rapid assessment of the uterine activity because eclampsia usually stimulates uterine activity. They can actually have a ruptured, they could rupture their membranes or increase their signs of labor or have an abruptio placenta. So monitor their uterine activity. Do a rapid assessment of cervical status. Is she dilated or not? And fetal status, check heart tones, and determine whether you need to do an immediate delivery or not. Now, postpartum, we need to be watching these women. Remember, I said the first 24 hours seems to be the most dangerous. So we need to do a careful assessment of how much blood they've lost and signs of shock. Hypovolemia is caused by preeclampsia, and that is because it may be aggravated just by that normal blood loss of delivery. Assess for signs and symptoms of preeclampsia for at least 48 hours postpartum, so they may continue to make sulfate postpartum. And the signs that we look for that she's recovering from preeclampsia is her urinary output going up to 4 to 6 liters per day, the decreased amount of protein in the urine, and then gradual improvement in serum blood values. So they want to continue to monitor labs, and the return of the blood pressure to normal. And that may take a while. So it usually changes within 2 weeks, but it could take as long as 6 weeks postpartum for that blood pressure to go back to normal range. And this is ending the hypertensive portion of high-risk perinatal.